Hello, and welcome back to the Oncology Brothers podcast. Intermediate HCC is a heterogeneous group requiring multidisciplinary approach. Today, with Drs Nina Sanford, Ed Kim, and Mark Yarchoan, we had a chance to discuss more off-liver-directed therapies along with immunotherapy. As we continue to see the data in this space with multiple combining regimens, that is, durvalumab with bevacizumab or pembrolizumab with lenvatinib, Nina, first, we need more representation of radiation oncology for BCLC to have a truly multidisciplinary approach. Can you please touch on some of the modalities available for radiation oncology in this space, please?
Historically, it's sort of fallen into three buckets, sort of downstaging for transplant, more the systemic with greater disease burden, and then sort of in the middle, the sort of destination local therapy. I think the lines are blurring between the three, though, with hence the need for combination therapies. But I think radiation has a role in all those sort of three frames. If we think downstaging to transplant, then radiation could be used as either bridge or downstaging, in this case for intermediate risk, if they're initially above the Milan criteria, both in UNOS downstaging. If we think of destination local therapy, historically it's been TACE and now TARE. I think radiation has a role as well in for more well-defined isolated tumors that are intermediate stage. And then the last is historically patients who have been treated with systemic therapy. There is emerging data on the combination of radiation and systemic therapy as well.
That's great. Thanks for touching on this, because as a community oncologist, it is so important for me to partner up with my neighboring radiation oncologist. And as an interventional radiologist, what are your thoughts on the data that we have in hand, be it for EMERALD-1, where we have durvalumab with or without bevacizumab with TACE, and LEAP-012 with pembrolizumab and lenvatinib with TACE?
I think that both of those trials were read out as positive, with the primary endpoint being progression-free survival, and they're roughly similar, about 15 months. The difference, I think, in trial design between the two is that EMERALD-1 was really successive therapies. You do the TACE first, and then you add really the bevacizumab. You start with the durva, and that showed a benefit in terms of the primary endpoint. And then LEAP-012 was concurrent therapy, so really started at the same time with their regimen. I think most people are kind of a wait-and-see approach with both EMERALD-1 and LEAP-012, looking at how is the median OS going to read out.
I think to call these trials positive, they really need to show an overall survival benefit.
Mark, I'm sure you got some interesting thoughts from a medical oncology standpoint.
When we look at the LEAP data and the EMERALD-1 data, it's very early data, but I do think that it sort of supports the general natural trend that's been happening anyway, that systemic therapy has moved earlier. And really, the hope is that if we can move systemic therapy earlier, number one, we don't miss opportunities for patients to get systemic control. But number two, we can really focus loco-regional therapy on treating oligoprogression or residual lesions or debulking in the setting of systemic control, rather than just using systemic therapy as a last result.
Nina, anything to add here from multi-D tumor board discussion?
I think for those of us who are focused on the local treatments, it's really important to know the other local treatment. I think the potential of transplant is what really complicates things and can sometimes complicate the decision for local therapy.
Mark, your final thoughts and key takeaways?
It's a great time to be a medical oncologist because we actually have things we can do that meaningfully help patients with HCC. I think we have some intriguing early data about combination therapy that fits with a broader trend, but longer term follow-up is clearly needed.
Ed, your key takeaways from today?
It's essential to work within a multidisciplinary team for just multiple levels, patient care, the whole aspect of patients potentially going to a curative transplant. And again, working with our medical oncology colleagues to hand off patients and as Mark had mentioned, to receive patients back. We've had patients that have gone on several years off of checkpoint inhibitors, but checkpoint inhibitors what initially got them there, and then they have breakthrough progression, and we can perform loco-regional therapy and still keep them, maintain their performance status and their underlying liver function.
Nina, Mark, Ed, thanks so much for your valuable insights. multidisciplinary approach is an extremely important aspect of medical management, especially when it comes to HCC. And these conversations continue to reiterate that.
This discussion concludes our 4-part series on HCC. We had a chance to cover available treatment options for intermediate and advanced metastatic hepatocellular carcinoma. Make sure to check out our other 3 discussions in this series. Thank you for joining us. We are the Oncology Brothers.